Hey guys, I'm David, PGY3 here, along with Abra and several other residents. We sort of came together and formed this team. So it is our hope that throughout the academic year that we'll be able to bring you more talks like this, guest speakers, as well as, sort of other type of sessions where we can have open discussions about issues surrounding social justice, health, justice, and everything. So we're very excited. Thank you for joining us. And this is sort of our first talk in our series. And this is our attempt to make our talk interesting, cardiac bias-opsies. And so the paper that we wanted to really talk about and introduce, the whole concept of like social justice and biases is this journal that came out of New England Journal of Medicine in 1999. So the effect of race and sex on physicians' recommendation. So emphasis on physicians' recommendations for cardiac catheterization. I also want to give sort of a shout out to Dr. Cheryl Sistrunk, who is actually a Georgetown residency, resident. She completed her training in, I believe, 1994, so she was a part of this study. This study, not only was this the first study, I think, to really look at the sort of addressing the differences on cardiac interventions, I guess, between race and sex. It was looking at whether or not the physicians really played a role in these differences. So prior to this study coming out, many epidemiologic studies have shown that invasive cardiac procedures such as cardiac cath or bypass surgeries, the rate differed based on race and sex. And specifically, Black women are less likely than white men to undergo these invasive procedures. And a lot of studies looked at them factors that may have caused these differences: insurance status, access to hospitals with cath labs, patient preference, symptom presentation, and the differences in the clinical presentation of these patients. But there were no studies that looked at the extent we as physicians are responsible for the differences in treatment recommendation with respect to sex and race. Okay. Next slide, Abra. Okay, and that's our shout out to Dr. Cheryl Sistrunk. So the study method was, I don't want to say simple. It was very well thought out. So it composed of a computerized survey. So it was a multimedia sort of survey, incorporated text, recorded video interviews, and EKGs even, that essentially presented a patient with chest pain. So all of them had chest pain. And there were essentially 6 experimental factors. So race, sex, age, coronary risk, the type of chest pain, and then exercise stress test. And you'll note that the test for the exercise stress test, they were all positive. But what the experimenter did was essentially create unique combinations of these factors. And they came up with a total of 144 unique patient presentations. Some of the other factors that were included, they were given lipid panels, they were given a smoking history, and sort of depending on the risk, the coronary risk, the lipid panel will reflect of a higher risk, or like the smoking history will reflect a higher risk. And then they have also controlled other things, such as, no one was diabetic. Everybody had the same family history, which was MI in the father at the age of 75. So essentially what happened was physicians who attended the the American Academy of Family Physicians Conference in 1996, and also the American College of Physicians in 1997. So all these physicians who went to the conference, they were asked whether or not if they wanted to participate in this survey. If they did, they would then go into this like private booth in which this whole sort of simulation is almost like a Cytel kind of thing that we do, but this whole simulation would have started, and then each doctor, each physician that took part in the survey were displayed one of the 144 unique scenario. Okay, next slide. Okay, and then, like I said, so the survey itself, or the entire process, had text, descriptions of the chest pain and everything, EKGs, but they also had a recorded interview by actors. So 8 different actors recorded these scripts for to be shown to the physicians. And so these are, if you recall the age, it was either 55 or 70. Sex, male or female. So this would be, female, like the top 2 actors, age 50, bottom actors, 70. And then there are 4 other actors that were white. Again, they represented, there you go, age 55 and then age 70. And then and then physicians were also given an EKG that were essentially the same. None of them were, of course, a slam dunk for, acute coronary syndrome. So they were essentially just EKGs that had non-specific T-wave findings. Next slide. Yeah. So when all of these, when all of the information was given to the physician, they were prompted near the end to first characterize. So they wanted the physicians to assess or to evaluate the type of chest pain that the patient had, and then also to estimate whether or not the patient presented to them had significant CAD, which is essentially defined by greater than 70% epicardial artery narrowing. So the physician had to say whether or not they thought this was like, oh, this is like typical angino type pain, or this is not, pain associated with CAD, and then they had to estimate whether or not they had significant CAD. And if they did, they were then asked, hey, did you want to refer your patient to stress test? And they have 4 different options for a stress test. Of course, there's, if they didn't think that the patient has significant CAD, they could just say no, and the simulation would have ended there. But if they did want to refer the patient to the stress test, they had, one of the 3 to choose from. And remember earlier when I showed you the experimental factors when it came to the stress test, they were all positive. So when the physician thought that patient might have significant CAD and wanted to pursue further testing, they would have gotten a positive stress test result. And then the next step would have been, do you want to refer this patient to cardiac cath? So yes or no. And then, and that was essentially the entirety of the simulation. Okay, next slide. Yeah. And then I do also want to mention a little bit, after this this algorithm, they also asked the physician to, I guess, assess or rate their interactions of the patient. So there were characteristics or factors that would influence, I guess, the physician's perception of the patient. So whether or not they thought the patient would be able to follow up on the treatment, would they be compliant, and all of that stuff. So they wanted to make sure, they wanted to control for these different factors that would have then influenced the physician to either recommend cath or not cath. Okay, so the result. There wasn't anything that was in terms of referring the appropriate patients to cardiac cath. The older patients, I believe, or thought to have significant cath when they had the elevated coronary risk. So the physician who participated in the study were sort of like bang on in terms of their estimate of the probability of CAD. However, when it came to the intervention, next slide, so I can highlight the box that were. Is it coming up? Yeah, there you go. So in terms of recommending intervention, so the difference for females, the odds ratio you can see is 0.6, and that was statistically significant. So meaning the female patients were less likely to be referred to cardiac cath. And then when we looked at race, there you go. So comparing black to white, of course, black patients, again, odds ratio 0.6, and that was statistically significant. So, yeah. And so like I said, sort of that after they selected the interventions, I talked about the questions that the physician had to take to sort of talk about their thought on the patient's ability to like follow up, to be compliant, all of that. When they did the analysis, or I should say the analysis that was done here, also controlled for all of those. So the physician's perception on the patient's personality did not bias their results. Okay, so then the study conclusion. I'll give you guys a second to read that. Okay, so just to summarize, the author concluded that physician biases, likely subconscious, affected patient recommendation. And of course, when we think about what that would mean for the patient, Black females were referred to cardiac cath less, which of course would then impact ultimately, right, the quality of patient care, but also outcome for our patients. Okay, so, and that's sort of exactly what I said. So why does this matter to us? So biases can affect the quality of patient care and ultimately the outcome. So this is the reason why we wanted to sort of use bias as one of the first talks we have. So understanding bias, I'll give you guys a second to read this. And for those of you who have seen this example, there are multiple versions of the example out there. If you have already done this, don't give the answer, but for someone else who have not seen this, please feel free to let us know what you think.
Does anyone have like any initial thoughts or responses to this?
Is it in the chat box? The answers?
Oh, it's in the chat.
Oh.
Yes. Yeah. The first time I encountered this was a surgeon, actually, Dr. Cruz.
So I would just comment. It actually came from one of the residents when we use this one, but there might be another bias at play other than gender.
Anybody? The first time I read this, I will be completely honest, I did a double take because my first impression was that this didn't make any sense. So when I read it the second time, I was like, oh, okay. All right, David, you did not consider that the CEO was the mom. So, and that, you know, that for me, it was like a mind-blowing moment. I was like, oh, God. But so that was my reaction to it. So
I had the exact same like moment as you, David. When I first read through this one, Zema was one who kind of shared this story with us. I was like very confused, and I was actually a little embarrassed that I didn't actually figure it out.
Yeah, definitely. I caught myself right after. I was like, whoa, like how really? Like I was almost in disbelief. But so.
Yeah, I did a Speedy Thomas from nephrology, but I had it wrong too. And then we did the similar surgery question with the residents, and then they were like, well, what if it's a homosexual couple and not a heterosexual?
Right.
So that was the other bias that I realized I didn't even think about that. So why it could be two dads as opposed to being one has to be a dad and a mother too.
Right, and that's kind of what I thought first, but it just kind of I don't know if that makes me sound worse, guys, that I thought it was a homosexual couple first before I jumped to it being a woman. So you know, and I think these are things that are very important for us to realize. You know, and this is exactly the reason why we're sort of introducing, you know, this series.
Right. You know, bias is not a bad thing. Just recognize it.
Yeah. Okay. So, so sort of moving on to a little bit of definition. I know that, you know, most of us have gone through sort of bias training, or at least have exposure to this in our medical school education. But just to sort of state this, so explicit bias, so the attitudes or beliefs, whether it's positive or negative, that we consciously hold and express about a person or group. And explicit and implicit biases can actually sometimes contradict each other. Explicit bias usually show up when humans are afraid. So, example, I don't think a woman would make a good president. Women are too emotional. So I do think that in our current political climate, you know, explicit bias is, or actually I should say racism could be a form of explicit bias. But the other part of it, which is, you know, implicit bias, these are, you know, attitudes and beliefs, whether, again, positive or negative about other people, ideas or issues that occur outside of our conscious awareness and control. So we can't really access these cognitive shortcuts that we have. We develop these cognitive shortcuts from very early on in life. So they help us process the world when we're like overloaded with information. And these biases, they reside deep in our conscious, and they're different from, of course, the known biases that we're aware of. And you know, and those biases, explicit bias, we can choose to conceal those, right, in situations or for the purpose of social and political correctness. But implicit bias, we have no control over. But it's important to know that, you know, so if these are sort of outside of our grasp, outside of our consciousness, are we able to then change these over time? And yes, we can. And that starts with being able to identify and becoming aware of the actions that are then a result of your implicit bias. And then, so why is understanding implicit bias important? So, you know, as physicians, the main thing that we really want to focus on is, of course, how it impacts our ability to deliver care, good care for our patients. So, you know, understanding the causes of our implicit bias and being able to push back against the consequences, you know, our actions and everything are critical to the movement, you know, of social justice, racial equality, healthcare, or the elimination of healthcare disparities. And again, the main thing for us really is to be able to provide good care to our patients.
So now that we've kind of talked about implicit bias and significance, and David has kind of gone over and given like great examples of why implicit bias matters for kind of what we do on a daily basis, we're just going to spend the remainder of the talk kind of going over a topic that you guys actually requested. So in addition to kind of talking about healthcare articles that demonstrate implicit bias, we sent our survey out a couple weeks ago. You guys expressed interest in talking about ways that we as a residency program can actually tackle bias from a practical standpoint. So we'll kind of spend the remainder of the talk going over that. Before I do that, I just wanted to briefly introduce the PAUSE method. So I think most everyone has heard of this if you've had some exposure to implicit bias training. This is a slide that we borrowed from Dr. Thomas, one of his presentations. So I'll let you guys read through the acronym yourself. But as you may already be aware of its purpose, the whole goal of the PAUSE method is really to kind of bring awareness prior to kind of entering a clinical situation, literally taking a mental stop and thinking through, you know, what are ways that my bias or my potential biases may come up in an interaction that I'm about to have. So a practical example would be if, you know, before you go see a patient in the emergency department that you're going to admit, or before you pre-round on a new patient in the morning, just taking a couple seconds to kind of stop and think, you know, jot something down or quickly run through it in your mind, you know, based on the patient's age, gender, sexual orientation, socioeconomic status. Are you already starting to form a picture in your mind of who this patient is? Are you already starting to form assumptions about this patient? So that would be a practical example of actually using the PAUSE method. So how do we kind of potentially use PAUSE as a medicine team? So we did a lot of research looking into what does work, what doesn't work, and what has actually been shown to be potentially harmful in terms of implicit bias training. And some of you may know this already. I think this was discussed at the most recent town hall. You know, there has been evidence to show that implicit bias training can have some positive effects, but oftentimes they're only temporary, and meaning it's not something that is seen to be lasting. There's even been evidence to show that mandatory training, like so in instances where companies have forced their employees to actually go through implicit bias training, for individuals for whom, you know, who are very resistant to the idea of kind of addressing their own implicit biases, this can actually backfire, because essentially with the thought that people don't react well with the thought of somebody else trying to control what they're doing. And so that can actually potentially have negative effects and reinforce stereotypes for people that are resistant to this training. What has been effective and kind of what we found, and this has been true across like Fortune 500 companies, HR firms, is fostering a workplace culture that promotes two specific things. The first is social accountability, and the second is team engagement. So when we were brainstorming as a team, this was kind of our framework for our framework. So how do we actually go about changing a workplace culture? Again, this is another slide we borrowed from you, Dr. Thomas. So we know that leadership and leaders play a really big role in kind of setting the tone for what a workplace environment will be like. And in the sphere of kind of what we do on a daily basis as residents, this actually applies to us in a lot of ways. Within, you know, a given medicine team where we have attending, sub-Is, and med students, we as residents and even as interns, we carry a lot of leadership responsibility and roles. And so there's a lot of opportunity whenever we move on to a new rotation each month, whenever we have a new medicine team, to really kind of set the stage up front for how that team is going to function. So here on this slide, we just have a sample script that a team leader could potentially use to even really broach the idea of implicit bias to their team at the very beginning of the rotation, and kind of set the precedent that talking about implicit bias and tackling it together as a team is something that's important to do over the course of the month together. And so this kind of ties into that whole idea of kind of team engagement, cueing your team early on when you guys are first meeting each other and getting to know each other, that team engagement and talking about this is important. So how do we actually do this on an inpatient setting? So this is a schematic. This is a representation of our team's kind of working idea of how this could potentially function on an inpatient medicine team. So on the leftmost panel, we have kind of the resident and attending role, or kind of team leader role, that would be done at the very beginning of the rotation. So kind of what we mentioned on the previous slide, this whole concept of, setting that stage early and leading by example. Oftentimes residents or attendings will do like orientations or very brief debriefings with the team, especially with like students and sub-Is, over like the expectations of how the month is going to run and how each team member will function. And we felt that this is something that could be very easily integrated into that brief orientation, just spending literally a couple of minutes to broach that topic of implicit bias and lay that framework early on. So the middle panel is kind of what would be done on a team aspect, so that the team engagement component of this. And so depending on your comfort level, you could do this weekly, you could do this bi-weekly. And the whole thought behind this is that you would set aside maybe 5 to 10 minutes of time and have 1 to 2 team members kind of share their experiences. An example of a patient experience that they've had during the rotation where they felt their implicit bias was at play. So the whole purpose of this is kind of talk things through, share with the team that you're working with, what was the situation that you felt was challenging? How did you actively have to work to kind of combat that bias for that patient interaction that you had? And then the last panel that we have on the right is just practices that you could sprinkle in throughout the remainder of the rotation. So kind of going back to that pause idea. This could be done on an individual basis, and it certainly doesn't need to be done on every single patient. But if you make it a habit of every now and then, let's say when you pre-round on a new patient in the morning, just take a moment to practice that pause. It's something that you could potentially share in your team debriefing, and you could even try it as a team. Oftentimes when we round as medicine teams in the morning, if there's a new patient, we all round together, and you could practice this on 1 to 2 patients throughout the rotation. We do want to say that, if this speaks to any of you, if it sounds like anything that you're interested in, that's great. If it is something that you feel like adopting in some way in your practice throughout your time on the inpatient wards, it won't necessarily feel comfortable. In fact, it may actually feel really uncomfortable at first. Talking about implicit bias is not necessarily natural for any one of us. And let alone even sharing with people that you're working with examples of your own bias can actually be very vulnerable, and it won't necessarily feel natural, and that's totally okay. These conversations are not easy, and they're not meant to be easy. We actually, during one of our team meetings last week, we had a member share that he did something very similar with one of his sub-Is recently on a rotation, where he kind of brought up the topic of implicit bias at the beginning of the rotation, and he shared with us that it felt really uncomfortable, and that's totally okay. It's our hope that this is really just this framework that we have here that we're proposing to you guys is really just a tool. It's not a quick fix for addressing bias. It's really, from our perspective, kind of a starting point for having engaging conversations with each other in the workplace about biases that happen in real time, and that this is something that we can continue to grow and develop. And we also want to say that this tool or this kind of framework that we have proposed to you guys is definitely not mandatory. It's totally up to you whether or not you want to do this. Your attendings will not be expecting this of you. This is not part of like a curriculum. This is just totally a resource if anybody is interested.
And kind of also want to add to what Abra was saying, that I think a lot of us are worried how we will be perceived if we do identify and talk about our own biases. And it's our hope that that we should be free to sort of engage in these conversations, talk about how we feel about ourselves, identify the biases in ourselves, and feel comfortable to vocalize that publicly without, feeling like, uh-oh, how would, Dr. So-and-so see me now? So we just want to encourage that sort of a safe environment for this type of discussion going forward.
Yeah, no, that's a really great point, David, that no one should feel like sharing this is gonna reflect badly. We should, if you choose to practice this in a team setting, recognize that it is very vulnerable to share this stuff. And it's not something that reflects badly on a person for sharing that they have these biases. So this question slide, or the slide of questions, is really just a primer for the previous one. So I'll just let you guys read through it. So if you are struggling to come up with examples of situations where you felt like your bias was at play when you're interacting with a patient, these are just some questions just to kind of get your mind going. If you're struggling to come up with examples. So thinking about, did you have a patient interaction that was frustrating, and why was it? So kind of forcing yourself to think a little bit deeper. So like I said, you guys can read through this. I think this PowerPoint we can make this available to you guys, and it's on Microsoft Teams. So I'll let you guys just read through that on your own time. And then these are just some questions that we'll leave you guys with. These are kind of questions that kind of came up for us when we were brainstorming. We don't have the answer to them right now, and we don't expect you guys to, but these are kind of where our thoughts kind of naturally went when we were talking about this. We care for patients, on the wards, but we obviously take care of them in a lot of other settings as well, including clinic and critical care settings too. So we have started to think about, what are other ways in which that we could potentially adapt this to a different setting. Clinic functions differently from inpatient wards, and critical care is totally different from inpatient, just the workflow. Yeah. So just some things to think about for potentially the future.
Yeah. And of course, Abra, we came up with this inpatient workflow. I've worked in the Georgetown clinic outpatient, and we have time set aside for the noon pre-clinic conference, and I think that would be an ideal time to sort of work this into the outpatient workflow. And I think, in the outpatient settings too, we at least residents, right? We in a day could potentially see up to 12 patients. So that's 12 individual sort of opportunities for us to practice, pause, and really think about how our feelings, our judgment, and everything can really take or play a part in our interactions with these patients.
Yeah, for sure.
Dave, can I make a comment?
Yeah.
Mm-hmm.
Great job, by the way. I would add a third question. As we look from us towards patients, but also us as mentors and mentees, and to the med students. We're all mentors in some way, right? Whether it be attending or resident, but incorporating bias so bias happens in mentorship as well, right? So when you have medical students and you're teaching them, if they come from a certain medical school, that might bias you. The other things I really think of is what career paths you guys choose as residents. From the same way we say in our lecture, you don't want to do cardiology, Why do you want to do this field? Why do you want to do this? So another thing might be important as you pick your mentors through your residency and training, is to consider how bias might affect that if you have the right person for what you want to do. And in microaggressions of kind of whatever career path you choose might not be what someone else wants you to do, and that's okay. You know, you should be able to choose what you want. But I think it's our doctor-patient interactions, but also us as our academic interactions can also be included in that. That was the only comment I wanted to make. But great job, guys.
Thank you.
No, yeah, I definitely appreciate that comment. I think it's great to, you know, also step back and think about the interactions that we have with each other. And I think thinking about that, and that could even be a whole separate talk in and of itself. But that's a great point. But yeah, that's all we have for you guys. Thank you so much for tuning in. We do have a team on Microsoft Teams, so if you ever want to just chat with us or share ideas, etc., you can find us there, and just kind of reach out to any one of us.